All right, thank you for joining us, Dr. Purakal. So we would like to kind of talk a little bit about your EMF grant project that you did this past year. But before going into that, I would like to kind of ask you what drew you to Duke and how is Duke supporting what you're doing here at the university?
Sure. Well, thanks for asking. My wife and I were very drawn to Duke because of the culture and the camaraderie within the faculty group, as well as the infrastructure. They have a great infrastructure for research and for collaboration. And so we very quickly kind of felt that when we interviewed and came down here. So and it's held to be true, now 2 years in, feeling that we have ample amounts of opportunity for research, and we have all the support that we need within our division and within our department to complete, projects that we kind of seek out to do and have the ability to collaborate with others in doing so. And so people are very forward thinking and always trying to help each other out, even if it doesn't necessarily benefit them in any way. And we were really drawn to that sort of work culture. So
That's great. And so, as far as now jumping to the EMF grant project that you were working on, so what would you like people to know about the project that you were doing?
yeah, the Emergency Medicine Foundation was generous enough to and kind of again forward thinking enough to have a grant out regarding COVID-19 research very early on in the pandemic, and so it allowed research that was going on while the pandemic was unfolding itself. So all of it was happening in real time, and we were fortunate enough. Our team was fortunate enough to obtain one of the grants to look at social determinants of health, both from a qualitative side of things and get to interview patients who had been affected by COVID-19, and also to use geospatial mapping and figure out where the patients who had been infected that were in the Duke health system, where they lived. When we kind of cross-referenced it in with social determinants of health from the North Carolina Department of Health and Human Services, we created two separate maps. One looking at disproportionate social needs, things like living below the poverty line, low access to food or healthy food, health literacy, language barriers, things like that. And we had another map that looked specifically just at COVID outbreaks or hotspots, if you will. And what we did is we took those two maps and we kind of overlapped the two and tried to see if there were any associations that we could make between the two. And what we found were that in the areas where there was a disproportionate amount of social need, so the areas that had worse unmet social needs, had significantly higher rates of infection. Even though geographically they were much smaller than their counterparts, we found that the rates of infection in those areas was much higher than the areas that had kind of equivocal social needs or had more protective or positive social needs. And so that's held true throughout the country. And it was very interesting to look at our own patient population to see where those areas are. Similarly, going back to the qualitative side of the whole thing, we saw a lot of themes that were very interesting. Some things that we had suspected or hypothesized, and then others that were kind of surprises along the way, specifically in the aspect of communication, how folks decided to talk about the infection once they had it. That was a very interesting piece that we didn't really anticipate, that there would be such a large spectrum of responses. We had certain groups of people that felt that this was something they needed to keep to themselves, and there was almost a sense of shame about having the virus and not wanting to let other people know about that because that's your personal business or your own medical history, if you will. And then there was the other side of the spectrum where folks were saying, we need to talk about this. And, this isn't, we even had one person quoted as saying, this isn't HIV. This is something we need to talk about so that other folks don't get it because it's spreading so rampantly. And so it was a very eye-opening experience to kind of see the different themes in terms of what people found to be most profoundly affecting them in their course, whether it was the ability to isolate, the ability to get support from the community or from family members or anyone else, And then if they thought that social determinants of health were playing a role, and almost unanimously, all of them had varying levels of concern about social determinants of health playing a role in either how they got it or how the community at large was responding to the pandemic.
Yeah, wow, that is a lot of information. So where do you see all of your work kind of helping us move in the future?
I think that moving forward, this number one, going to the mapping study that we did, we had an understanding that social needs and social determinants of health were being put under a microscope during the pandemic, and our study kind of helped to, or at least has shown that this is held true kind of in our area as well. And we're hoping that this helps us to provide sort of more targeted interventions. Right now we're experiencing this wave of the Delta variant, and the way things are going, we don't know how long this cycle that we're going through is going to continue. And so we're hoping that once we kind of show this information to in our area, showing that it holds up, that maybe we can target interventions, whether it's using community organizers or community leaders in those areas to help us educate, provide resources, provide testing, provide masks, gloves, hand sanitizer, whatever it is. We can have more targeted interventions to try and equalize those rates of infection. We're not going to be able to necessarily drop the rates of infection to zero, but you want that disproportionately higher rate in the areas of unmet need to be closer to the other areas. And so that's what the goal would be, to have the hospital system as a whole kind of invest in those areas so that we can maybe see a reduction in those rates. And then from the qualitative side of things, I think understanding folks' perspective on this and their health beliefs, right? We know health beliefs drive health behaviors. And so this is, if we can understand why they think that they got it, and what their beliefs are about the virus itself and how it's transmitted, and how their living situation or their financial struggles or their access to food or to their healthcare providers, how those things play a role in their experience of the pandemic. Again, that goes back to being able to tailor how we intervene and how we interact with our patients, and being able to understand where they're coming from when we treat them or speak to them in a more public setting. And so I think all of this will help us kind of have more tools in our tool belt moving forward, because this pandemic was definitely a wake-up call in a lot of ways for us, that maybe we weren't prepared for something like this to happen on such a large scale. And so studies like these, I think, will help us moving forward to be as personalized and as specific in the care that we provide, the education we provide, and the interventions that we provide for our patients.
That's very well said. Thank you. Um, well, thank you again for taking the time to kind of share your amazing work with the community. And we look forward to seeing more of your work in the future.
Great. Thanks for having me, Erin.
Yeah.